right below her kneecap. Hitting, jumping, running, and squatting make her pain worse. Over the past 3 weeks, she has rested, avoiding any pain provoking activity, only to have the pain return immediately upon resuming activity. She claims that to have normal menstrual activity, but tends to skip meals in order not to miss any practice sessions. Based on this patient's report, guys, again, let's go in order. What would you suspect the diagnosis to be?
Patellar tendinosis.
What clues from the patient's report lead you to this diagnosis?
Pain under patella, resting didn't relieve symptoms when returning to sport.
Good.
And pain when patient is jumping and landing.
Which answers my next question. So what hurts more when they're doing what kind of stuff?
Jumping, squatting, running,
Jumping, squatting,
landing.
Yes, those are the big three. Okay, next. What specific activity, active movement testing can the patient perform to reproduce these symptoms?
Single leg squats or double leg squat.
Yes, have the patient in the office do that. If symptoms increase at the inferior pole or right below the apex of the patella, then that's leading you to even closer to your decision that it's patellar tendinosis. Patellar tendinosis, yes. What hip, knee, and ankle deviations would you note while the patient performs activities described in section D?
Okay, excessive femoral internal rotation, increased excessive knee valgus, increased excessive foot pronation, and imbalanced by irritation of the patellar tendon in close kinetic chain.
Okay, so what will it look like? Somebody show us. Yes, and that's called what?
Miserable.
The miserable malalignment. That's the miserable alignment.
Imbalanced by irritation of patellar tendon in close kinetic chain.
Yes, and the deeper the squat, the more it will be painful to them, right? The deeper the squat. Good. Palpation. Somebody lie down. Where exactly would she complain of pain, and what is the best patient position? Get a bolster. I try to get him sleeping next time. Go. So how would we?
I guess so.
All right. How would we? What's the best position to feel?
Alright, so it's gonna be flexed about 20 to 30 degrees. Gonna go right at the apex of the patella, and then just be right there.
All right, and you push hard, and the patient should be
In pain.
in pain. Very good. So ideally, the person is long sitting, not lying down. Don't ask me why. The research says long sitting. Good. Name one, and it's 20 degrees of flexion, like you said. Name one ankle-related intrinsic factor that can lead to this diagnosis.
Limited dorsiflexion in the patellofemoral joint.
Yes. Do you know why? Or speculate why?
Because there's weakness in the gastroc and the
But why would decreased range of motion in the ankle lead to possible patellar issues, patellar tendon issues?
Have to compensate them.
Yes, so the less dorsiflexion I have,
the more
yeah,
the more heavy.
Force on quads.
could be.
Yeah.
The
More
you
force
do-
on the patella, yes, the patella is getting this force when it should have, yes, I'll buy that. All right, name two extrinsic factors that could contribute to this diagnosis. In order.
Footwear and poor training.
Oh, by the way, did anybody notice this?
Yeah.
Oh,
What's that for?
I just put it on.
Nice taping.
Yeah. All right. Good. Poor footwear for poor training. What are tight or inflexible in this patient typically? What?
Bilateral hamstrings and quads.
All right, but they're both bilateral hamstring. But which one would be worse? Would be more
On the
tight.
Side where is the pain.
Yes, the affected side is worse. Very good. All right. What else?
Ipsilateral abductors and gastrocnemius and soleus.
Gastroc-soleus, abductors, but what else? So you said
Glute
Glute
medius,
medius,
IT band.
good. All those are tight. Glute minimus, medius, TFL, and IT band. Good. Manual muscle testing. Next, we'll reveal weakness in what muscles? List 4.
Quads, glutes, hip abductors, and hip internal rotators.
Those are weak. Very good. Perform special tests that correspond to the above mentioned weakness and tightness. Show us all the special tests.
So Thomas test, you can supine, and you're gonna bring your knee to your chest, and if you see that her,
So the patient holds their knee in their chest. Good.
so if her hips are off the table, then positive for tightness
In.
in her hip flexor. So
And what if they have? And what if their hip is totally in neutral, but their knee cannot flex to 90 degrees?
Then the other quads are tight. The other vastus, vasti.
Vasti. Everybody get that?
The vast guy.
You got it. So good. That's a positive sign. Is that he just explained it? Good. What's another special test?
There's the Ober test.
How does the Ober test go?
Mine's sideline. Okay, and the top leg is gonna be the knee is flexed, hip extended, and if the leg drops, then that's normal. But positive sign would be if the leg doesn't drop and you let go of the leg, and tightness in the ITB.
Good. I like to do it like this. Don't. You had your chin. Good. That works too. All right. Well, how about this? One more. Show us Eli. Clothes, please.
Wrong, and the knee should be flexed.
No, Joanna. You don't do it on yourself.
So I passively bring the foot to the buttocks, and if there's pain, if there's tightness, then that's positive test.
No. What's a
Her-
positive sign?
Her hip would come off. the
Their
table.
hip flexor pops off the table, showing us, yes,
It's gonna be like that.
showing us that means that her hip flexors are so tight they can't lay on the table. Got it? Got that? Those 3 tests?
Great.
And those tests are good for every diagnosis to prove that you have tight hip flexors. It's not just for this diagnosis. Do you understand that? Do you understand that, Mr. Mitchell? Of course they do. Okay.
Of course.
We don't want robots, you know that. All right, now teach active and passive patellar tracking somebody.
Who's the one with the happy face?
So we'll mark Joanna's knee
All right, where do you mark?
at the inferior and superior poles of the patella,
Okay, where else?
and on the medial and lateral borders of the patella,
And where else?
and right in the middle.
Smiley
Show,
face.
do it, show us.
Come on, Picasso.
Look at that. Look how much they're learning, Mr. Mitchell. It's amazing. All right, good. Now what? So what's the patient position?
In short sitting.
More than that.
Tripod.
90 degrees of flexion and tripod. They're not lying down, their hands are behind them.
Hands over.
And why do we do tripod?
Oh,
It relaxes all the muscles, right? You don't want those muscles tight.
Right.
You want them relaxed. Good, okay. Good, they're not torn, right, okay. Yes, see, when you actually have to do it,
yeah. So I'm gonna passively bend her knee and straighten her knee, and look for excessive swaying.
good, but
outside
don't
of-
touch the patella, because then you're gonna affect how it moves. So just point, I point to the middle one, do it. So full flexion, point to the middle one, and you're watching that middle dot. And then you passively take her into a full extension, and you see too much. Normal, a little lateral and medial movement of the patella is totally fine. Excessive movement is not fine. And then you do the same thing with her, with what? That was passive, and now
Active.
active. So you point to that center, look at it, so you have a visual, and you have the patient,
Okay, straighten your knee.
and you watch the same way. Watch for that excessive lateral movement.
That's good. Slowly back down.
Very good. Okay, good. Very good, guys.
I can see.
We've never had really any abnormal tracking here that I've no. A person that has bad patellar issues come in and say, hey, my patella.
So
They
it
come,
must be really, really bad to see
to
this
see a lot.
thing.
If you have these symptoms, yes. I see it in the clinic, but I never saw a student have it. Okay. Perform a specific special test for this diagnosis. Please perform it. This is LaGuardia School of the Arts.
Flexion, passive extension flexion sign done in supine. Yeah,
Action the patient. Sure.
Okay, so, talk this one out. You love talking it out. Let's talk it out.
One moment.
So basically we'll be flexing the knee, should be about 20 degrees. So when it's in flexion, there shouldn't be much pain because the tendon is taut. But when I'm extending, there should be pain right at the apex.
Start over again. The patient starts in full extension.
Alright, full extension, I look for the apex.
Yes.
I get the patellar tendon.
And you push, and then what happens? Wait, they push, and the patient says what?
Says ouch.
Ouch. Okay, then,
And I bring them into flexion.
how many
and
degrees?
About 20 to 30.
90.
Not good.
90.
Degrees.
No, they can have their foot on the table, doesn't matter. 90 degrees, and then you push again.
And then should be less pain.
Should be less pain. Why?
Because the tendon is taut, so then that way there's not much. Well, I know because the tendon is taut. That's one of the reasons.
Yeah, so when the tendon is taut, it protects itself from the tendinopathy. So you push it, it won't hurt because of the tautness. When it's nice and loose, then you push, it hurts. Okay? And Michael had a question.
What's the name of the test, Alan?
Passive extension flexion test.
All right, there's another version of this test, also known as the what?
The standing active quad sign.
The standing active quad sign. All right, what? Somebody do it.
Okay. Patient. Okay.
Just standing, same concept, except you're gonna flex.
Standing
Wait,
at
Now
first.
again, you start at extension,
Start an extension. Where at the apex.
you push, and the patient will say,
Ouch, there's pain. And then now he squats.
Just to get 20, 30 degrees of
yeah,
flexion.
and you're
there.
pushing by the patella tendon.
It
Yes,
should be
and
fine.
and
There's no pain.
when you, there's was person single leg standing?
Single
Oh,
leg.
Single leg.
Should be fine. No
So
pain.
the pain decreases in 30 degrees of knee flexion in standing on one foot. Again, the same concept. When the tendon is taut, it protects from the pain. Everybody get that? Everybody know how to do that?
Mm-hmm.
Good? All right. Any questions thus far from this fantastic group of kids? Any questions? No, we're good. All right, you guys are good. All right, fine. Treatment time. First, hamstring stretch with passive quads. Go get a thing.
So
Go.
you could
Want a
do
belt?
it,
Here.
You could do it in long sitting, reaching for your
It's a little
toes.
bit warm, but don't worry about it.
You could do it in long sitting,
Long sitting.
reaching for your toes, or you can do it lying supine with the legs
Show us.
flexed
Show us with that belt.
against the wall.
Keep full.
Show us on the floor. Move stuff away.
What is this for?
Can't find a wall in New York.
Now bring your butt closer to the wall. So the idea is you want a hamstring stretch, but you don't want to activate the quads. Good. Too bad you can't make your board now. Pictures like that. And what's away with the with the belt? I wore that belt at my wedding.
Oh, be careful with it.
Yeah, what are you gonna do with it, Alan?
This should be flexed. Passively bring it up. There you go.
There you go. So that's passive quads. Very good.
Your
Now,
toes are hanging out.
quads with posterior pelvic tilt to incorporate rectus femoris on table and in standing. You want this?
Alright.
Right? Standing.
One
Or,
more.
okay, I can do that.
You show us in prone or standing, whichever one.
Good?
Yeah, that's good. All right. And in standing?
Standing, just
Turn
Pull up,
against the
pull.
door.
and then
All right, do my lazy way. stand by the table, face me. There you go. I like that, it's lazy.
And do your lab.
All right, show us thank you. Show us gastroc and soleus stretch. You said runners, right? I like it.
Alright, so feel up a little bit against here if you can, or maybe any type of wedge that you have. And then you're gonna pretty much just, you said gastroc and soleus?
That's not runners, but that's
Oh.
fine. No, that's good, that's fine.
So go right up against, you should get the gastric and soleus, to get just the soleus, you bend a little bit.
All right, show me a runner stretch, just to make somebody no one knows it.
You make like you're gonna push the wall down, so your back leg is flat, knee is straight to get the gastroc, and then knee bent to get the soleus.
Already got that. Heel stays on the floor. Back knee straight. Back knee a little bent for the soleus. Back straight for the. Both are good. I'll take both of them. All right. Good. How do you stretch the IT band?
There's
Well, he's that to me.
this stretch where
Yeah.
the leg goes behind one leg, and then you reach towards that
Right.
leg.
That's
Or
a
you
good
could do,
IT band stretch.
Or you could do foam roller.
Anybody have any questions on foam rolling, or you got it?
Got it.
Any questions on foam rolling? We went over it at least twice. Good. All right. Good. Now dynamic stretching. How do you stretch the hams and the glutes dynamically?
You can do
Somebody.
toy soldiers, so reaching for your toes,
Okay.
or you can do high knees.
High knees, good. Remember we talked about that you're getting, so the high knee stretch which muscles?
Hip flexors.
The glutes, all right, and
wait.
and doing that by actively firing your quads, you're gonna reciprocally inhibit your glutes. No questions from that, about that, okay? And what's the other one? And now to actively,
Quads.
yes, to actively stretch your quads? Yes, donkey
Butt
kicks or butt kicks. You're actively firing your glutes
Heels,
to
glutes.
stretching your quads. Good, very good. I love it. Show us the eccentric protocol we talked about in class. Somebody else, Joanna, you want to show us the eccentric protocol?
No.
You don't want to. Okay.
With the wedge in the back. Is that it?
Can I do something else?
Yes. Who would like to show
I
us?
am confused.
It's all right. It's okay. Who would like to show us the eccentric protocol?
So I guess.
I mean, it's only my
Alright,
favorite
so
thing in the world, and
So
you won't do
basically,
it.
there's gonna be a wedge over here.
No, let's not pretend. Let's do it.
That's your wedge.
Come on down. Or
Just like this. If you want, you can have a backpack.
Well, we're start the first level. No
If you
backpack.
want.
If you want.
First level, no backpack.
Alright, first level, no backpack.
Yes.
Going down like this, squatting.
Now it's one. So you're going up with both feet because the concentric we don't care about. We only care about the eccentric. So you go up with both feet, then you stand on the one foot,
And then
and you go down to 60 degrees, eccentrically very slowly with the one foot, and you come back up with both feet.
up.
Up concentric, I don't care about.
And then
It's the eccentric I care about. You got that?
Gotcha.
Very slowly, eccentric protocol. If you don't have a wedge for that my patient made, you could use something like that or a book. What is the protocol?
So
How many sets do I do of this?
so for the first 1 to 4 weeks, it's about 3 sets.
Joe, you'll have your chance.
Yeah.
3 sets of 15 for
3 sets of 15,
3 times a day.
3 times a day.
For and then let's say you're having hard days and you can much do no eccentric.
What do you mean hard days? Like I have to go to class? Like what does hard days mean?
That's like I guess
What does a hard day mean?
exam days.
just pains times when it's like a lot of pain, I believe.
No, heavy lifting days. It's specifically to an athlete. On heavy lifting days, you don't do this exercise.
And then hard
But
days.
other days, you do 3 sets of 15 3 times a day. Any questions on this? We're good? Yes? Okay. Good. Now the patient, after doing it, says, hey, Joanna, I have 4 out of 10 pain. What do you say to them?
It's okay.
It's okay. Pain is good.
No pain, no gain.
Pain is good, all right? According to Alfredson, pain is just fine. So after 4 weeks of doing this, then how you advance it?
Go to a stable surface or with increased weight using a backpack.
So the patient should wear a backpack or an unstable surface, like, the BOSU, which we have a BOSU. You have them stand on the bolster so they're on a decline. You know how the bolster's like a dome? They stand not at the apex of the dome, on the side of the dome, so they're facing, and then you do the same thing, or even that.
Yeah,
It's kind of an unstable surface as well. Got it? You can even do it on the tilt board. Do it on the tilt board. Flip over the tilt board.
Even to this?
Flip it over. Yeah, flip it over. Don't let me not get on top of that.
Just
Good.
take-
Now go. No, no.
No.
Put the whole foot on the tilt board.
On the middle.
Whole foot, but
Oh,
enough
I'm
where you're
close
at a
to tilt board.
decline. Stand on one foot, and then do it. See, unstable surface.
Yeah, that's,
Alright. Be in the middle. To be safe.
but that's not a decline.
Yes, but you take a little, if you come a little bit forward, you'll have the decline. There you go. That's an unstable, I'll buy that as an unstable surface. Up with two legs, down with one. You got it?
A little bit of this, so that's dangerous.
Good. Or you can try it on the ball. Go, do it on the ball.
Huh? You?
No, I'm
Just-
kidding, don't do it. All right,
I'll give you
so,
$100 if you can do it on
very
the
good. Next,
Ball
so that was week number 4. Now, how about some strengthening? Progress from open to close. Hip abduction, open chain.
Theraband, just like this.
Theraband or cuff weight and standing, hip abduction. You do it in sideline.
So abduction and sideline, right? You got that? Abduction and standing.
On the side.
I'll buy that. All right, so show me now a closed chain hip abduction.
Wide base support, going side to side. Side lunges, basically.
Side lunge, I'll buy that. Or you can even do a side plank.
Oh, yeah, I like that.
Oh,
Look.
yeah.
That's also closed chain, I'll buy that as well. You got this closed chain, good. Hamstrings.
You can learn it in front.
So first, yeah, open chain hamstrings, strengthening.
So for open chain, you can lay on front, put some calf weights,
Or Theraband.
or Theraband or something.
Theraband
like
around
that.
the ankles.
Or you can do a straight leg raise in
Leg
prone
raise.
Straight leg raise in front. We have
with the cuff weight. Good, that's open chain. Now what about closed chain?
And oops.
With the ball, closed chain with the
I
ball.
can't do that.
As it always me.
The only one with skills.
Yeah, it's still on the
Bring it close to you first, bring it close to you, flexion, walk it, now bring your left, good. No, we did it, we showed you how to do it already.
Walk the ball.
Good, now that you're here, one foot,
Uh,
and now butt off the table, butt off the floor,
It's up.
huh? It's off. You like that? Good.
I like that.
I like it, glute, that's very, yes. Single leg roll in the ball, good. Good, how about, glute max?
in quadruped, you
Here,
can.
donkey kicks.
Donkey kicks, that's open chain, good, I'll buy that. Now what about, some closed chain single leg stuff?
Deadlift,
Show us a one-legged deadlift.
one
One-legged.
leg, one leg deadlift. Okay, okay.
So
Yeah, not
either-
bad,
Yeah.
but you want,
Either do-
but deadlifts are a hinge, it's a hinge exercise. Good, yeah, when I do a single leg, I tell the patient, like,
You either
bring
have
one
a-
foot back, so you're really hinging.
Right. You
Good.
do bridges.
You could do bridges, what
Single
else?
leg.
Single leg, what else?
Squats.
Single leg squat or double leg squat, I love it. How about the last? Joanne, you wanna do deep friction on the patient's patella tendon?
Yes,
Dig in there.
Good.
Flat.
so ideally, his knee
Okay,
is
I'll buy
flexed,
that, 20 degrees, there's
20
your bolster,
degrees,
there's
so-
your bolster.
Okay, thank you.
Good, all right.
So we have to find patella tendon and do deep friction massage
Yes.
in opposite direction
Yes,
of muscle
horizontal, good.
fibers.
Good. I like it, very good.
It's painful, really? No, right?
Keep friction, yeah.
Any questions? Any questions on patellar tendinosis? Good job, guys. Group number 2, let's do it.
Woo! Thank you guys. Appreciate it.
What? Oh, I didn't have that. Perform, oh, proper eating habits? So what would you tell them about proper eating habits?
Eat more and
Don't miss, right, you could, according to Dr. Wallace, we can now do nutrition. But I would say, I'm not a nutritionist, but skipping meals does not sound good to me.
Right.
We should speak to your coach, speak to your parents, saying, hey, you're not getting the proper nutrition. Skipping meals to not to miss practice is not a good idea.
So to give them any advice, we have to be certified?
No, according to Dr. Wallace, now you could give some advice, but I'm not a nutritionist, but I'm gonna say.
Yeah, you're
I'm
not gonna
pretty
give
sure
them, like,
skipping meals is
doses
no
or
good,
something.
But getting them, if it's a student, I would tell mom or dad, say, she's missing meals, it's not good. She can't be missing meals. You know, address it, don't ignore it. Okay,
Let's get in the picture.
good, all right. The patient feels like the knee is giving out during aggressive sports-related movements. Currently, her pain is 8 out of 10, but she knows that the pain will decrease with rest. Her goal is to return to volleyball symptom-free. The sport-specific movements that increase pain and swelling include running, cutting, jumping, and pivoting. The doctor asks that you try conservative treatment before surgery is considered. All right, what's this diagnosis? Oh, patellofemoral syndrome. Okay, says it right in there. Demographics.
Adolescents and adults, females more than males.
Okay, good. Patient will complain of what type of specific pain when performing what type of non-sports related movements?
It's diffuse pain and anterior side of the knee.
Diffuse anterior knee pain. Good. Doing what movements? Non-sports related. Everyday life stuff. What?
Going up and down stairs,
Stairs,
squatting,
squatting, prolonged sitting. All put undue pressure on the patella. Very good. What are the possible anatomical causes of this diagnosis?
The lateral facet of patella is not optimal height.
Therefore,
It tracks laterally.
The patella
Right.
is tracking laterally.
so since the lateral, what was that you said? The lateral facet of the lateral facet of the femur, of the epicondyle of the femur, is not the proper height, and therefore when the patella tracks laterally, because it doesn't have the proper, the lateral side should be higher than the medial side. So the patella is translating laterally, but it's not moving properly in the patellar groove, okay?
Wait, you said the lateral side is higher?
The lateral side should be higher, but in this patient it's not, therefore the patient has lateral tracking. All right, manual muscle test will reveal what?
Weakness in hip extensor muscles,
Hip extensors,
hip abduction muscles,
hip abductors,
hip external rotation,
hip external rotators,
and core muscles.
weak core muscles. Okay, do you know, and you don't know all the muscles that do all those movements, of course. Range of motion tested will reveal what?
Decreased knee extension,
Known as?
screw home
Yes,
mechanism.
yes, that's the mechanism, but they have decreased terminal knee extension. They don't have full terminal knee extension. What might be the cause of the issue? Yes, their screw home mechanism is decreased. They don't have a screw home mechanism. Patellar tracking, that team just did it. We're not gonna show it again. But make sure you hit all points of the patella and the center. Patient is in tripod. They do it passively and actively, watching for lateral tracking. Okay, good. 3 tests to evaluate the above mentioned weak musculature in closed kinetic chain.
Standing Trendelenburg, single
Okay.
leg squat, and
So what would a positive Trendelenburg look like? Or how would you have the patient be? So you have the patient stand on one foot,
yeah.
and
If
then,
it's weak, then the pelvis will slope down to the opposite side.
everybody got that? So if the patient is standing on their right leg, their left hip will drop because their right abductors cannot hold up the body. You got it? Turn around, show just somebody show what it should look like from the
What it
back.
should look like?
From the back, what a Trendelenburg sign looks like from the back. So face that. There you go. Yeah, so we're testing,
Yeah.
we're testing Liz's right side, but her left side drops. That's a sign that positive weakness for the right abductors. Okay, good. What else? You said standing Trendelenburg, what else?
Single leg squat.
Single leg squat and,
Step down test.
what's the step down test?
Um,
Get a step. We have a
down
step here?
is
Here's a
right
step.
there.
Here's a step.
Candidates. You would like,
No, it's to the sides. The patient stands, if you're using your right foot, which foot are you using? Your left foot could stand all the way to the, there you go. And they just step down. And when they step down, you would see what if they have issues with weakness that we talked about.
kind of like,
They'll have a miserable malalignment, right?
yeah.
Right? The hip will adduct, or whatever you want to call it. The knee will give in to the valgus force, and they'll have pes what? Plantis. You got that? So they have them step off the side. You have them step forward first, but I like stepping off the side better. It really gets it. Good. And they would present with a miserable malalignment. We got the miserable malalignment. We said it a lot of times.
We got a lot.
Good. All right. How about another test that you could do? Who's wearing shorts? No one in this group is wearing shorts. Oh, you are. To see if there's
Darren has
swelling
retractable
behind the kneecap.
pants though.
Oh, to see, right? See if there's swelling.
Swelling. Clarkson.
This thing?
Yeah.
Oh.
You did. You did. Yes.
You want me to do it to you again?
Yeah.
Win one.
Sounds so true.
Okay, so use the web of my hand, and I feel the inferior border of the patella. Yeah. So I ask the patient to flex the quad, and I stop the patella going up. The patient will feel pain.
Yes. Everybody got that? The web space stops the patella from going up or superior, and then the stopping of it will push it into the femoral in the intercondylar groove. If there's swelling behind the kneecap, that will increase pain. How do you test core?
Single leg bridge.
Show us that.
Single.
Some-
I've done it like 3
Come on,
times.
Joey.
It's always the same. It's always Joey that does it.
He's got a good,
I got a
he's
hardcore.
got a good core.
All right.
He's hardcore.
So that is exactly the position. Elbows off the table. Not like that. We can rest it on your body. Up higher. There you go. That's like that.
Oh no.
There you go. There's your positive sign. So if there's too much swaying horizontally or vertically, officially 10 degrees. We don't have a fancy machine to do it, but that's you stop the test. If they hold it for 23 seconds, then they have full core strength. Good. All right. Treatment. Early phase 1.
23 and a half.
Hip extension using both lower extremities.
Bridges.
Any question on bridging?
Next.
All right. Hip external rotation against gravity. Show us, Kevin.
Do clamshells. You have a band around their.
No band. Was it early phase?
Early.
Did no band. Just gonna go up. Using gravity.
There you go. That is hip external rotation. Very good. Hip abduction against gravity.
What did we? Single leg raise on the side.
Come on, you know how to do it. You don't have hip abduction day in the gym?
But I really like. I want that hip in. So extend your leg. Extend the hip.
Extend the hip.
Joint mob to improve hip knee extension. Femur on tibia, going posteriorly or anteriorly? Posteriorly. Do you understand that? Go back. I'm saying it on film, right? Go back to the joint mob lecture, lab rather, and get to know it. Practice it. Just because we're not doing it again doesn't mean you don't have to do it in the practical, because you will. You do it right. I don't want to get pissed off for no reason again. All right. What's next? A joint mob specifically to address the screw home mechanism. We should do it with an exposed knee. Somebody should have exposed their knee.
Mob up.
Oh,
Pain.
okay, still.
Pants gang.
Oh look, the corners are coming up.
See, I told you, you gotta cut them off. Go.
Staggered.
So
Lay
the
down.
patient is
Supine.
supine. Good.
90. Get up in there.
Yes. You want to make sure you want to make sure that the leg isn't slip. Get your fingers behind the deep in that popliteal fossa. There you go. Look for gold. Now what? Yes, but when you get to the end range, do a grade 4 at the end. There you go. Grade 4 into full tibial external rotation. Got it? I'm just looking for a grade 4. Oscillation at the end range. Got it?
Good.
Hello, got it? Very
Great.
good. Huh? Someone said something? Oh, great.
I said great.
Thank you, Ryan. Next, core strengthening in neutral pelvis. How do we do core strengthening in neutral pelvis? Show us a plank. Kevin's working overtime today. So, that's neutral pelvis? Okay, good. What's another
I'll buy
neutral
that.
pelvis? Posterior pelvic tilt, even though there's a little bit of movement, I'll take it. Good. All right. Very good. All right. Now, late phase 1. Hip extension, single leg. Single leg bridge.
Show
I
us.
like it. All right, I'll take that. Hip external rotation. TheraBand against gravity. Same thing. Clamshells with TheraBand around what? The knees. Very good. Hip abduction. Cuff weight. Oh, cuff weight. Very good. Hip abduction lying down. Cuff weight. Joint mobs to improve extension. Again, the same one. And screw home mechanism, the same one. And core. How would you do a more aggressive core?
Hollow holes?
Show us a hollow hold.
Yeah.
Yep, there, dude.
Semi hollow.
Mr. Mitchell, get the.
No, your knees were
ball.
bent.
That's a good thing.
Yes.
Ooh.
There you go.
There it is.
There you go. Hollow hold. Very good.
Well, that's good.
Yes. Phase 2. All right. When is the patient ready?
2.5
for
longer
phase 2,
than
guys?
usual.
What do I mean? No exacerbation of symptoms or compensatory patterns.
So now you're going to strengthen and standing, right?
Correct.
Good. All right. Glute medius and core.
Show us.
Do isometric against
So, yes.
Yeah,
Yes.
it.
Yeah.
Something.
And push and push because when you're doing that, you're strengthening your abductors and you're getting your core involved. Good. Glute medius. This is standing now. Glute medius. Single leg squat or single leg deadlift. Right? Either or. I mean, these guys did it before. Hip extension and standing. Yes. Backwards walking. I'll buy or that. Very good. Joint moves are the same. The screw home is the same. Good. All right. When is the patient ready for phase 3? 5 out of 5 strength in glutes and external rotators. All right. Dynamic core stabilization with physio ball. And do it as, huh? That's what you guys did.
DKTCCP.
Show us. Yes.
Oh, I never saw
No, that's what we did.
That's what you did. That's I put it in there. You did it.
Alan. That's fine.
No, that's the one that what's his name did. that Dennis did.
I don't know if I can do it. Can you do it, Soy?
Oh, the pike?
The pipe underneath the chest.
Yeah. There you go.
There you go. 30 more of those. One hand. One hand. No, okay, don't do it. All right. Now the patient is ready for plyometrics. Obviously, you're going to go back to your plyometric lecture or lab, and you're going to pick a low, a medium, and a high. So you're going to name them, but everyone knows that we went over it, and you'll go back to the labs to make sure they do it right. So give me some lows for jump progression.
Squat jump.
Squat jump. Jump and reach. 2-foot ankle hops. Good. What's a medium one? The one that put Josh in the hospital over there. That wasn't the one? Which one?
Tuck jump.
Tuck, double leg tuck jumps. What else?
Box jump.
Box jumps. What else? Split squats.
Yeah.
And the high is?
Cycle split squats.
Good. How about the hops progression?
From the real.
Front barrier hop. Could be low, medium, and high, depending on how high you make the barrier. I'll buy that. That's what you guys said. I like that. Standing long jumps would be a medium or a easy?
Medium.
Medium, for sure. Standing long jumps. What else? What's a high?
Zigzag.
Zigzag. And also a lateral barrier hop could be a medium. Good. Taping, we just showed you how to tape. Everyone should practice. I told everybody to chip in $2 and buy this.
I don't know if I can do it. Can you do it, Soy?
Oh, the pike?
The pipe underneath the chest.
Yeah. There you go.
There you go. 30 more of those. One hand. One hand. No, okay, don't do it. All right. Now the patient is ready for plyometrics. Obviously, you're going to go back to your plyometric lecture or lab, and you're going to pick a low, a medium, and a high. So you're going to name them, but everyone knows that we went over it, and you'll go back to the labs to make sure they do it right. So give me some lows for jump progression.
Squat jump.
Squat jump. Jump and reach. 2-foot ankle hops. Good. What's a medium one? The one that put Josh in the hospital over there. That wasn't the one? Which one?
Tuck jump.
Tuck, double leg tuck jumps. What else? jumps. What else? Split squats.
Yeah.
And the high is
Cycle split squats.
Good. How about the hops progression?
From the rehab.
Front barrier hop could be low, medium, and high, depending on how high you make the barrier. I'll buy that. That's what you guys said. I like that. Standing long jumps would be a medium or a easy.
Medium.
Medium for sure. Standing long jumps. What else? What's a high?
Zigzag.
Zigzag. And also a lateral barrier hop could be a medium. Good. Taping. We just showed you how to tape. Everyone should practice. I told everybody to chip in $2 and buy more tape. I wonder if they will. This is all we have.
That roll?
We ran out and the budget's closed. I have another roll. But go on Amazon.
If we don't buy it, we're gonna retest it.
Oh!
Everyone's getting taping. Yeah, everyone's getting taping.
It's all on camera.
The John Deere duct tape.
Oh, the duct tape.
No way.
After that. All right. Okay, very good, guys. Any questions from case number 2?
Why you got ball
Woo!
Number 3 is the stupendous. All right, are you ready? So this is a 35-year-old cell phone technician.
Cell phone.
I don't know where I don't know. It must have been late at night. Comes to your office after a sports-related injury. I guess from fixing cell phones. He sustained while playing flag football with his nephews this weekend. The script from his PCP reads: extreme left knee pain, evaluating treat, assess soft tissue integrity. Upon interview, the patient claims he twisted his body on a planted left foot when avoiding one of his nephews, but also remembers being hit on the outside of the knee. Okay, so what structures might be affected based on this?
MCL, medial meniscus, or ACL.
Right, so you guys don't know based on his thing. It's a mystery. So now we want you to perform all special tests to rule in or rule out
I'm gonna be the
what
patient.
diagnosis it might be.
Josh.
You're the patient?
Well, Josh is not. He actually.
All right, so this is important, so please make sure you do. Which ones are you going to
What
do
about
first?
Joe?
I'll be walking ACL one.
ACL, no, we do the ACL ones last.
Oh, that's right. We have a dramatic.
Let's do athletes first.
Okay,
Yes,
so then we'll do.
So what are you doing first? You're doing
Yes.
meniscus first?
Yeah, okay, we'll do that one.
No, I'm asking which one are you doing
Yeah,
first?
meniscus is fine.
Meniscus first. Do you think it's medial or lateral?
Well, we're gonna do. Oh well.
Based on the story.
He has. It's medial.
Okay, because he was hit from the side, he twisted. Okay, good. All right. Which test are we going to do first?
We'll do. Yeah, we can do. McMurray.
McMurray. All right, talk it out.
So his tibia, he's gonna have his knee. His hip is gonna be slightly flexed. I'm gonna externally rotate the tibia like this, and I'm gonna apply force going medially, and then I'm gonna bring his knee into flexion, and then I'm gonna slowly let it come back down. And if there's pain, then that's a positive sign.
Right. So you're going to externally rotate
The tibia.
the tibia, and so the patient starts in flexion.
Oh, he's already in flexion.
He's already in flexion. You're externally rotating the tibia,
Okay.
and you are then you're applying valgus force, and you're putting your index finger on the medial joint line. And as you're going into extension, you're applying a valgus force. And a positive sign would be pain. To test the lateral meniscus, which is side point, you're just doing the opposite. You're doing internal rotation
You put your finger on the lateral joint line, and you apply a varus force.
as you're going
As you go
into
into extension.
extension.
Positive sign is pain on the lateral side.
All right, good.
Okay.
That's the first test. You
So
got
it's
McMurray?
Yeah. The
Good.
second one is Thessaly or standing.
Well, yes, it's standing.
So you're
30
basically.
degrees deeper.
Joe, you want to do it?
It's a McFlurry?
So do it. Get in there.
And then he's just gonna twist.
What's this called?
It's called Thessaly.
Thessaly.
Yeah.
Got it.
He's twisting and there would be pain.
His knee is bent to how many degrees? 30
30.
degrees.
That's exactly 30
yes.
right now.
Most
Nailed it.
Most places where I've read about this test, which by the way is one of the best ones, the therapist is holding the patient's hands so they don't fall.
Yeah.
That makes me uncomfortable.
Right?
Do the twist.
Now you can't see.
As you did last time.
So positive sign is pain.
Positive sign is pain. Very good. You're rotating how many times?
3.
3 rotations. Very good.
So you can go prone.
Thessaly. Sorry, not Thessaly.
After this test,
Can't turn anymore.
So you're pressing down and you're going like here to here.
Grind test.
You get on the clink and you put your leg
Oh, that's
up on
right,
it.
yeah.
Well,
if you're tall, you could do that. If you're short, I'm just gonna do it because I'm short.
Step
I
on
can't
the-
do-
on-
I can't do it like you do.
Get on the table.
I have to get on the table. and put mine here. And then. If you're tall, you could do that. If you're short, I'm just gonna do it because I'm short.
Step
I
on
can't
the-
do it-
on-
I can't do it like you do it.
Get on the table.
I have to get on the table and put mine here and then grind it. If you're tall, I guess you can get away the way you did it, but I really
Yeah.
And a positive sign is
Get a high-low.
high-low table. Yes, a positive sign is. So you did all of these meniscus tests.
He has a meniscus tear now.
You did all of these meniscus tests, all of them, right? And the patient is in no pain.
Wow.
All right. Next, you're gonna do what?
Can't get me.
MCL. Okay. What are the MCL special tests that you're
You
gonna
can
do?
do valgus stress test, inflection, and extension, so using those 2 points.
Okay.
You want to do inflection?
So there's 2 ways to do this, and that will tell you what kind of tear.
Oh, wait, no, sorry, you should be sitting for this.
Are you doing swing?
No, I'm doing the valgus stress test, inflection. You can do that.
The valgus stress is the one where you're lying down.
Oh, you are sitting.
The swain is the one where you're sitting. But the swain is the.
Oh, that's right, yeah, I have that.
So do swain.
You need
Not in my chair.
I wish I could be the patient and the therapist. Can you hold this for 1 minute? Thanks.
So I'm just going to stabilize his knee, and then I'm going to externally rotate his tibia. And a positive sign.
No, it's me. It's his MCL. Like this.
Oh, I thought it said externally rotating the tibia.
This is external rotation.
And valgus force.
Oh, I see. Swing test.
Yeah, external rotation, valgus force. Just
Oh, just going like this. Okay.
yeah, but you're providing a valgus force.
And then positive sign is pain. And the other one, the valgus stress test inflection.
So this is the patient is in supine.
Supine.
Good.
Release inflection. And then
So this is to see how bad it is, right?
yeah.
So my question first to you before you do this test: when is the knee more stable? An extension or 30 degrees of flexion?
An extension.
An extension. Okay. So then you're going to provide a valgus force both in 30 degrees of flexion.
Mm-hmm.
Yes, and in full extension. Good, and you're looking for what?
For excessive movement.
Yes, if there's a tear, you're going to be able to pull that. Ask Mr. Mitchell if he ever had to do that, but another time. You will see that sucker move. There's a full tear.
Right.
So,
grade 3.
so what is a grade 1?
Grade 1 would be back here at 20 degrees flexion if I do this and it's just pain and there's no excessive movement.
No excessive movement, maybe 0 to 5 millimeters, whatever that is. And in extension, any movement? None. That's a grade 1. A grade 2.
It's still in flexion, but there is excessive movement.
But not an extension.
But not an extension.
Right. So flexion will have some movement, but extension will have 0 movement. That's a grade 2. That's a deep sprain.
And then grade
Right?
3
And
is
grade 3, a full rupture would be what?
full extension, excessive movement,
Right. And we're talking more than 10 millimeters.
more than 10 millimeters.
But the patient doesn't have any of that.
Anyway, where were we?
And then lastly, we have ACL.
All right, so wait, these are all negatives.
So far.
All right, now we're up to the ACL.
Are you guys wondering what the diagnosis is?
I mean, I'm at the edge of my seat.
I'm literally at the edge of this table.
Cell phone technician.
Yes.
So an anterior jaw.
But wait, no, you want to protect the leg from. You want the knee at 90 degrees. Right up there. Rest it. Yes. Now, if it slips, we're all in trouble.
Yeah, you're in trouble, buddy.
Protect yourself. Always protect yourself.
There you go.
No, what do you do? You're
I was like holding it still.
Anterior draw.
Pull me right into it.
Anterior draw. So a positive sign is what, Joe?
So it would be like
Drool.
Excessive anterior movement of the tibia on femur.
Anterior
Very
drool.
good.
The draw
It
test.
did, and Joe's freaked out. He had to run away and call the other therapist to do the next test. What's the next test? Lackman's. Lockman?
Lackman.
Lockman. Maybe she's doing it. Lockman. So, when the knee is flexed to 20, there's no bolster here.
There's no bullshit.
The knee is flexed to 20 to 30 degrees and slight external rotation. Your hand is placed like no.
No. We went over this. You're applying, you're just something, you're applying it.
Oh, wait, it's like that.
Yes,
Yeah. Joe, don't get carried away here.
So you can do it. Your hand can be placed like this way, and then you tell it to relax. Because you don't want the patient to relax, and you do a nice forceful movement. And again, increased movement's no good. So slight external rotation. Up.
So it's gonna
that's what he was doing. He just didn't do it.
I can't see, but I couldn't see him. All right, good. Show us again, Joe.
Don't worry, we got them all on camera.
boom, boom, boom.
You got it? And it's very important that the patient relax. Good. And what happens? Then Joe really gets freaked out because it's a positive. It's moving forward. And what's the last test?
The pivot shift.
The pivot shift. How does that work? The hip is where?
It's in 20 to 30.
Okay, good. The knee is what?
Boom, boom, boom.
You got it? And it's very important that the patient relax. Good. And what happens? Then Joe really gets freaked out because it's a positive. It's moving forward. And what's the last test?
The pivot shift.
The pivot shift. How does that work? The hip is where?
It's in 20 to 30.
Okay, good. The knee is what?
Flex.
The knee is, no, full extension.
I thought you'd go into extension, you look for the drop.
No, you go from extension into flexion. So the knee is full extension. Start from the beginning. Hip is flexed to 20 to 30 degrees. Knee is in full extension. Slight internal rotation of the tibia. Good. Flex knee while you're applying a valgus force. And look for the tibia to sublux. Start it again. This is a finesse one, Joe. This is finesse. Full extension, slight internal rotation. No, your hand is on the lateral side. Good. You're slowly flexing the knee as you're applying a valgus force. You're watching the tibia sublux on the femur. A positive sign would be subluxing of the tibia on the femur. You get it?
And then we don't do it when we don't want to
No.
go back into extension.
No, just leave it like that.
All right.
Because if there's
Anyway,
no ACL and you do that movement, the tibia will sublux. Everyone got that?
Ah.
It will go posteriorly.
It looked like he was kind of pushing it.
No, you give me a valgus force, internal rotation, and it will sublux. All right? Hope you never see it. Okay, so the patient is positive for all those. And therefore, you guys conclude that what?
ACL tear.
It's an ACL tear, because the
Uh-huh.
ACL was negative, all the meniscus
knew
were
it.
negative.
Mystery's been solved.
The mystery has been solved. So, you go back to the doctor and say, we think it's ACL. The doctor's like, great, you're on the team. Let's screen him. But you know, this is an old guy who just fixes phones, so he's not an athlete. So let's not do the surgery yet. I need you to find out if he's ready to for this conservative treatment. Okay. So what are the impairments that might affect you from testing him to see if he's ready?
Swelling, pain, decreased knee range of motion, and quad weakness.
Which are all normal after an ACL tear. So you cannot test if he's ready for conservative management if he has all these issues.
Yeah, whether
Okay.
he has other injuries or not, whether or if it's just the ACL, and then whether he intends to return to the exhibit.
Oh, I skipped that one. Sorry. No, that's I skipped it. All right, sorry. I'm half
But
ashamed.
he
I'm half ashamed.
because he said he's not an athlete. Okay.
Yeah, so right. It's an isolated injury, which you guys considered. You figured it was an isolated injury
Right.
because everything else was negative, and he's not an athlete.
Right.
So then you go for the conservative management, but you can't do management yet because he has these issues that you mentioned.
Right.
How do we? This is back procedures too, is it not? This is why I love it, and this is why one day they want to, Mr. Mitchell. This is why they want to make it into a comprehensive plan, I suppose. All right. So what do we do for swelling? Name one thing.
Ice.
Ice. Very good. How many layers?
60.
No.
No.
See, trick question.
No.
Just a cold towel, a wet towel. What do you do for pain?
Tens.
Tens, ice. What's the setting for acupuncture tens?
Russian, is it 4,000?
That's for IFC. If you want, this winter, we're giving the course again if anyone wants to come for a refresher. Nobody. Nobody whatsoever.
Okay. We have time for that.
No, never. Okay, what do you do for the decreased range of motion? Give me something.
Passive range motion.
Pass, I'll bypass it.
Peanut.
And what do you do for the arthrogenic muscle inhibition they have from an ACL tear?
Russian stem.
Remember Russian stim?
Yep.
Isometric contraction.
Wait, we have Russians in next semester's class?
Ooh.
Yes.
I gotta watch out
Yeah.
when I say
Oh,
that.
yeah, you have at least one.
All right, I will not say what.
Yeah.
All right.
Oh,
No, one semester, I was just saying Russian stim, and the one Russian woman got up and left. I'm like, all right, she kind of goes, I was offended
Oh, God.
because of the whole history. I said, it's called Russian stim. Mr. Mitchell wheeled over, he goes, it says Russian stim. This is what it's called, it's not offensive to. So she thought that I was making fun of the whole Russian thing. No, because they got in massive trouble for all the cheating. I said, no, I'm not going political. It's called Russian stim. I opened the book, Russian stim. Luckily, it ended there. What?
Call it biphasic.
I'm gonna call it
Trust
biphasic.
Might come after me.
Trust me.
It's
Yeah.
called Russian stim.
This is really bad.
Over to learn.
All right. Anyway, I don't know. I'm talking about what happened in the past. Arthrogenic muscle inhibition, right? That's what the quad shut off after injury, like ACL. Okay. So now you guys fantastically get rid of the swelling, get rid of the pain, full range, nice and strong. What test do you do to see if they are ready for conservative treatment?
4 single leg hops.
4 single leg hops they can do without a problem, right? Good.
If their knee hasn't given out more than once,
Reported, yes. It hasn't.
self-reported.
Good.
There's 2 outcome surveys. They're called the knee outcome survey at ADL scale and the global rating of knee function.
And they all have greater than 80 on the outcome and greater than 60 in the global rating, whatever the score is. You don't have to memorize that. Good. So you go through conservative treatment. You are ready to treat them for the perturbation protocol.
Yes.
Show us the progression of the perturbation protocol. Shall you? I'll go. Please don't hurt yourself. What's the first or next thing you do?
Not the scooter.
Why am I starving? I went freaking vegan, that's why I can't eat any more plants.
Loser.
Alright, so to begin, he's going to have 1 foot on a stable surface, 1 foot on a rollerboard.
Oh boy. That's first?
I did 3 squares. That's typical, that's a pretty good size. If a person's really big, you might want to do more than that. But you're going to assess the patient first, yes. I cut 3 squares, and then I took the 2 pieces of tape together, and I put them right next to each other, and I folded it over, and I rounded the corners. Because if you don't round the corners, the pointy corners easily get caught in clothing, and then it comes off. In the real world, you must do alcohol rub, because if the patient has oily skin or uses any kind of ointments, this will not stick. So I always do alcohol because it will fall off immediately. We don't have to do alcohol now, but I'm just saying to do that. If you take rock tape does not believe in the pull. Kinesio tape does believe in the pull. So we'll pretend this Aries tape is Kinesio tape, okay? You do not want to put your hands on the sticky part because then it will lose its stick. Okay, we are going to take a pen and mark all the corners. Do you mind, Sue? All the corners of the patella. And again, if I push on the top of the patella, I could see the apex right there. See apex? We should. I push on the lateral side. You see the medial side is right there.
Those things to use.
I push on the, wow, your apex really doesn't move that much. I find the top, there it is. And then I push medially, and I see laterally, and then I put something in the middle, right there. Okay, so I then take my tape, and the first one I'm gonna put right on the medial border, right? So I'm not up here, it's the top of the tape goes on the medial border, okay? I take the middle of the tape, and I rip it off. As you see, as I rip, I am not touching the sticky part. Fold it over, still not touching the sticky part. Still not touching the sticky part, and I put it right on the medial border. And the more I rub, the heat creates a good sticking situation. So I rub it here, not doing any slack, not pulling it at all. Then I take the parts that are not touching the sticky and I pull. Bend your knee, bend, bend, bend. I pull about 40%, good. And then I come around and the ends are not sticky at all either. And I rub. So that's pushing the patella medially, which I want to do because it's laterally tracking in this case, right? And I want to pull it 40% and then push a little bit as I'm working that way. And in a perfect world, there are no creases because creases also come out, but good. Do you feel a little push? Medial? Just say yes, we're on video. Yes, good. All right, I do the same thing with the other side, right? They're cut. I go to the right to the middle. And you could be like dramatic. I'll show you how you can be dramatic. Fold it. Grab it like this. I put it on the lateral border now. Like that. Rub to make it stick. And then I hold it like this. And as bend your knee, I come around this way, only pulling 20%. You do that, it feels like right. But that was bad. Yeah.
It's never gonna stick.
Never gonna stick. And I rub to make it stick. And this could stick, if it's done well, it could stick 4 days to a week. I tell the patient to shower regularly. You do not want the patient to come and goes, I didn't shower, to keep it on. If it falls off, it falls off. All right, straighten your knee. Not bad. And it really, so ideally you should push it. That's it. Feels okay? And the patient, if they have lateral tracking patella, they should feel it immediately when they start walking. They should feel that support. So that's just one method. There's a million methods. I like this method. So